We're going to shift gears, and I'd like to welcome our first CHC Spotlight speaker, Cliff Ledwis. Cliff has over 25 years of experience in the community health services environment, including governance, executive, and senior management roles. Cliff is responsible for developing, implementing, and supporting innovative programs, services, and special projects, community initiatives and capacity building, human resources research, health system redesign, facilitation, multiple source fundraising, resource development, and partnership building. Committed to health equity with a focus on immigrant and refugees, non-insured, and LGBTQ populations. Currently, he is the acting executive director at the Access Alliance Multicultural Health and Community Services, a board member of the Alliance for Healthier Communities, and on the executive committee of the Midwest Toronto Ontario Health Team. Everyone, please join me in welcoming Cliff.
Great. Thank you, Aisha, for the invitation to be here with everybody this afternoon. And thank you, Dr. B, for that overview. That is the clearest overview that I think I've participated in terms of the types and the types of vaccines that are available. So that was really helpful. Here's on the screen is my presentation today. And I'm going to share it with you in terms of a three-stage story in terms of our experience around vaccine promotion and delivery at Access Alliance. So let's go on, Aisha, please, to the next slide. And then the next one. And then just so briefly, in terms of Access Alliance, we're a community health center that's located in Toronto. We have three main sites, Central, East, and West. There's three historical phases in terms of the work that Access Alliance has done. You see those in front of you on the screen. Our first few years were all about the foundation of the organization in terms of the founding communities and the priorities that we set, being the most disadvantaged immigrants and refugees who are coming into Toronto. Our second stage of existence was all about geographic extension. So we had a main site and really made a very conscious decision to move out into the community to be able to deliver services closer to home for the many people who were coming to Access Alliance. And then our third stage in our history really started around 2020, directly after COVID and impacted and influenced by COVID. And this was all about virtual amplification. So making the delivery of virtual service a much more common practice as part of our extension out into the community and to bring our services closer to home. And now, in fact, because of virtual service, we can be directly in people's homes without being snoopy. So that's a little bit of the history of Access Alliance. I want to point out that the populations that we serve are, as an umbrella, immigrants, refugees, and people without status who are in Toronto, resident in Toronto. We do extend that a little bit to people who may be first or second generation Canadians, where the immigrant or refugee experience is still very important to them as a population. So that's a little bit about Access Alliance. And then let's go on to the next slide, Aisha, please. So you'll notice that I love stages in terms of my presentations, and I'm going to talk to you a little bit about sort of our three stages of vaccine work. In the first period, the pre-COVID period, the work that we did in terms of vaccinating people, promoting the vaccine, looked and felt a very particular kind of way. So it was quite intensive and very focused on the provision of vaccines. So making sure that we contacted all of the people who were in our roster, making sure that we were delivering vaccine to specific apartments that had a large number of seniors, or to specific places in the community to make sure that those people would have access to a vaccine. It was very personal and it was very targeted in terms of the promotion that we did. The promotion wasn't widespread. It was very much about get your vaccine. This is how you can get your vaccine. Sign up here. We threw a really very wide net in terms of our work with vaccinations. So, let's hit everybody that's in our roster, and let's make sure that we throw that net really wide in terms of the community that we're serving. Lots of work in terms of internally, so clinics, flu clinics, shots for our own rostered clients, and delivering flu clinic vaccinations out in the community at very specific organizations. A lot of prioritizing for high priority groups. Again, very focused on vaccinating. I would say quite labor intensive because we had to put together groups of nurses, groups of community health promoters, groups of peer health workers, and launch those clinics. Monday to Friday from 6 to 9 in the evening. We would do clinics out in the community, all of the organizing, all of the pieces of work that go into that, and then being able to make sure that the vaccines themselves were safe, but moving a lot of labor, a lot of moving of people and resources. We also tried to make a lot of emphasis on options for people to be able to access the vaccine. So really taking a lot of responsibility as Access Alliance to make sure that we provided as many options, as many times, as many days of the week to make that available to people. And I will say that overall and in general, people were very receptive to getting their vaccines, and to listening to us in terms of how important vaccines were. Very little pushback overall in our work with the delivery of vaccines. And then if you can go on to the next slide. In the next period, the COVID period, here's again what we experienced in the COVID period. This time, a lot of focus on the COVID vaccinations, and some focus on some of the seasonal vaccines that were available. So again, very intense promotion, often targeting very specific populations, very specific communities. Initially, a low uptake on the vaccines, partly because vaccines were new, people were still scared about catching COVID, but lower intake initially, and then moving to a higher intake uptake, a better uptake. This work was very, very partner oriented. So lots of community agencies working together, putting very large flu COVID vaccination clinics together, really a lot of work together, not so much about us as just Access Alliance, but us as Access Alliance with many CHC partners, many community-based agency partners. A lot of focus on a range of delivery methods that went from individuals through to mass vaccination clinics and participating in those mass vaccination clinics. And we were often very concerned about that senior who was in that building who maybe had an ability issue and couldn't get out of their apartment to get to a mass vaccination clinic. So we would send somebody directly to that person's apartment so that they could get a COVID vaccination. Lots of focus, I'm sure many people will remember, lots of focus on increasing access, in particular to very specific populations who were not part of the uptake in terms of accessing COVID vaccinations, thinking about disproportionate population impact. So Black communities, for example, were a population that we focused on. Often there was a lack of uptake because of some of the trust and mistrust factors in those populations. Not good interactions with the healthcare system, not good interactions with being tested in the past or tested upon in the past. So lots of distrust and mistrust. And again, as a partner organization, working with other organizations to help get information, to help build trust in many different ways, so that the vaccines would be fully utilized. A lot more work on information and also clarifying and getting rid of misinformation. And of course, in this period, the rise of the anti-vax movement that was quite prominent in the cavalcade or whatever it was that went across the country, saying don't get vaccinated and it's wrong and don't do it. So huge rise in that, and we had to pay much more attention to that noise that was going on because it started to interfere with the relationships that we were building and we had built with people. So that's the COVID period, and then Aisha, if we can go to the next slide. Here we are now in the post-COVID period, and I know COVID hasn't ended, but the impact of COVID is certainly different than it was in that more intensive period. And this is what we see now, a much lower interest in getting vaccinated. So vaccinations are available, but a lot lower interest in picking them up. What we also see as Access Alliance is that the access to vaccine is much wider than it was certainly in the pre-COVID period. In Ontario, we see that pharmacies are delivering different types of vaccines. So our rostered population has more choice in where they can go to get their flu shot, get their COVID shot, get their RSV done. They don't have to come to Access Alliance. And so we have seen a drop in the number of vaccinations that we administer. But we also know that in our rostered population, people are getting those done, just not with us. They're going elsewhere. A lot more work now in terms of myth busting and really having to myth bust a lot of that misinformation that rose up in the COVID period, not just now about the COVID vaccine, but a lot of the misinformation that is out there just about vaccines in general and reluctance of people to utilize the vaccinations that are available to them. So a lot more emphasis on combating the anti-vax spread, a lot more work now in terms of factual promotion and education, as opposed to actually delivering or making the vaccinations available to people. I'm going to say that we are in a period of time that I affectionately, somewhat jokingly, but really seriously call a convergence of stupidity. And there's a number of things that go on in that convergence of stupidity. There is extreme ideology, often on the right, that is at play. There is a lot of emphasis on natural remedies. So if I don't eat meat, I'll be protected. If I inject bleach, I'm protected from COVID. If I eat that horse medication, I won't get COVID. These are sort of these natural, unnatural remedies that are out there that people are following, often to their folly. I'd also point out that there is a lack of generational experience with some of the hardships that people can experience if they choose not to be vaccinated. So we see the rise in measles. We see people rejecting polio vaccination. We see people rejecting vaccinations because they actually have no lived experience with how horrific some of these diseases and illnesses can be, the impact of polio, of what polio can do to a person, that people, Canadian-born people and immigrants and refugees in their home countries have experienced in the past. I think about my mom who, at 92 would say, people don't understand how devastating polio can be. Why would they ever reject getting the polio vaccine? It can completely change a person's life. So that lived experience isn't here in Canada, and so people don't know how horrific the results can be in not choosing to be vaccinated. I will also say that there are bad political decisions. That is part of that convergence of stupidity. So politicians making bad decisions, very short-term decisions instead of a longer-term approach. These are all pieces that, unfortunately, in that perfect storm scenario, seem to be sitting with us. And that's a huge part of the work that I think all of us have when it comes to combating that anti-vax sentiment, presenting factual promotion and educational materials, doing some of that myth busting that we now have to do so that people will be open to and trust the vaccinations that are now available. And then, Aisha, if you go on to my last slide, where are we now? I've talked about or shared some of those things. So to us, to me now, a much different way of working and delivering the work around vaccinations, a lot of emphasis changing from delivery to the promotion of vaccinations, addressing mistrust where mistrust exists. There's the increase in terms of access. So our job in primary care as a community health center is different now than it was 15 years ago. A lot more information on factual information, presenting factual information and myth busting, much more work around the anti-vax sentiment. So combating that anti-vax sentiment, and also a lot more emphasis on making sure that specific populations where distrust or mistrust exists will be able to trust the healthcare system, be able to trust primary care, be able to trust the importance of getting vaccinated. That's where a lot of our work sits today. So there you go. Thank you very much.